Okay, so now we're going to be going over giving an IM injection, how to prepare it, and then the different routes or sites for administering it. So we'll start with the preparation as always, and we're going to do our checks. So we're going to review the physician's orders again with our MAR and make sure they're correct and accurate. All our 5 rates match up. And are correct. So it looks like that all matches up. We'll just kind of put our physician's orders aside and we'll take our MAR with us to go prepare the medication. So that's part 1 of our first check, right? And part 2 of the first check is making sure that we do in fact have the correct medication and it matches our MAR and that it's reasonable that we can get that dose from this vial. So we have taken from the patient's drawer the ampicillin vial, and it's in a powder form right now. So we'll also be reviewing how to reconstitute a medication. Reconstitution is most commonly done with IV medication, so it's something you'll get into more later on. But it can be required for certain IM injections. It's not as common, but it's a good principle to understand or concept to understand. So we have here ampicillin for injection. And we want to make sure that it can be, it says right here, IM or IV use only. It's 1,000 milligrams, so we can get that 500 from here reasonably. And so we check the expiry date. It's not expired and it hasn't been opened yet, so it's not been used for other doses. So we'll put that aside, but we've done now the full first check. So before we prepare the ampicillin and get it ready, we don't know yet how we're going to turn this powder into a liquid. So to get that information, this is where your parenteral drug monograph will give you that specific recipe. So we're going to flip to our ampicillin, and again, the drug monograph is typically in alphabetical order. So here we have ampicillin, and I can post that monograph on UMLearn for you to review later, but you also get familiar with this in lab. But we know that it's an antibiotic. It can be administered by a nurse or student nurse. It's supplied as 500 milligram and 1 gram vials. So we have one of those 1 gram vials. And then it tells you, so if you have a 1 gram vial, to add 3.5 mLs sterile water for injection. And that will give you a final concentration once it's diluted of 250 milligrams per ml. So if we keep reading, IM is an approved route for this medication. So it says IM, and then it tells us again what to do, that we're going to need to reconstitute this 1 gram vial with 3.5 mLs of sterile water for injection, and that will have that same 250 milligrams per ml concentration once we're done. So we will put aside our ampicillin and we'll make sure that we have sterile water for injection available to us, which we do. And similarly, we just need to make sure that it's not expired or contaminated in any way. So this is the sterile water we're going to use for injection. So we'll just put our monograph aside for now. We've kind of gotten what we need from it for now. Again, you'll want to have your drug cards or your drug guide available to know more of the indications, contraindications, side effects, those kinds of things of your medications as well, right? So we're going to get these ready now per those instructions. So we're going to open our vials and get ready and clean our vials to get ready to draw up the sterile water. So opening the same way with the underside, getting underneath those metal tabs, or maybe it's a plastic flip top, and then we're going to clean them again. So cleaning them really well, starting at the center, really working around there for about 30 seconds, trying to get that clean, that top nice and clean, and we just kind of speed up for video purposes, but you'd want to make sure 30 seconds is actually a long time when you sit down and do it or count it. So we'll clean these and let them dry, and then while they're drying, we'll get our syringe ready. So to draw up the 3.5, we are going to use a 5 ml syringe. You just need a syringe that's obviously greater than the 3. So we're going to open it similarly to our others. only touching the barrel of the syringe and not contaminating any of the sterile aspects of it. And then same with our blunt fill. You would be using a new one, right? We're using one that's been opened. So you just would pull back and then not touch the hub of the needle, attach it via the lure lock system. And we're going to move around our plunger a little bit just to unstick it again. And we're going to go, each line is worth 0.2, so 3.2, 3.4. If we go between the 3.4 and 3.6, we get that 3.5. So you want to go right between there to get our 3.5. And now we're going to uncap our blunt fill needle. It's not a filter because these are not amps, they're vials. So we're going to go into our sterile water and we're going to inject our air. We're going to flip it upside down so we know we have our 3.5. Typically it will kind of push the fluid out for you, but you may need to pull on it a little bit to get it going. And again, keeping your blunt fill within the fluid there, and we're going to give it a tap. Get those bubbles off. They typically tend to sit on the plunger there. And so we're just going to recalibrate to our 3.5. There we go. And we're going to take it out of our sterile water. And we know that this one is clean, so we're going to inject all of our 3.5 into our ampicillin powder vial. So we're going to stabilize and inject. And you're going to want to, some air will push out. You can help it along taking out some of that excess air so that when you remove your syringe from here, it doesn't do a spray back because of the pressure inside the vial. So that was good, it didn't spray back or anything. And then you are going to gently rotate that vial until the medication is mixed. Oh, we want to do our scoop method, right? So scoop and press. We'll just put this aside for now. So we're going to let that medication mix in there. Similar to insulin, you can kind of help it along by gently rolling it in your hands to help it mix. Some reconstituted medications will dissolve or dilute a lot faster than others, and you'll just start to kind of get to know that. So kind of give yourself enough time if a medication needs to be reconstituted, that you give yourself enough time or give the medication enough time to dissolve. And you want to make sure that then it's completely dissolved with no sediment in the vial when you're ready to draw it up. So we sort of have a fast dissolving one and it's all mixed in there now. So what we read on our monograph, if you remember, is once this is all diluted, it's 250 milligrams per ml in here once it's diluted, like I said. So for our 500 milligrams, we're going to need to draw up 2 mLs. We could use this syringe again, this 5 ml. Or we could use a new syringe and a new blunt fill needle. So I'll just get a blunt fill and we'll use a 3 ml syringe so you can see kind of more typically because this is what you have in your kit as well. So I'm going to use the 3 ml, so we'll open that up again and we'll get a new blunt fill. Peel it back and attach it. And so we've calculated that we need 2 mLs to get our 500 milligrams that is due. So we're going to pull back on the plunger again, unstick it there a little bit and put it at 2 because we're going to instill air. And if it's been a long enough amount of time, you can re-swab the top of your vial and let it dry. It's not a terrible idea. Especially if, again, it was one of those ones that took a while to dissolve and you had to sort of set it aside and do something else in the meantime. You want to guarantee that that is clean before you inject or withdraw from it. So we're going to remove our cap, I'm going to stabilize and try to inject right at the center again. And we're going to instill that air, flip it, and we're going to let it come out. And we might just have to help it along again. And we're going to give it some taps here while it's in there, or we could take it out and take out a little bit of extra, but that was pretty straightforward to get the bubbles out. So we're at 2 mLs of our ampicillin. We'll remove it. We'll recap before we remove our blunt fill. And then again, similar to with subcut and intradermal, we're going to pull back before we change over our blunt fill, so that all the medication is in the barrel of the syringe and not in your blunt fill needle that will ultimately go into the sharps. And now we're going to want to get our needle for injection. So I will attach that in a similar fashion as the others, and then we'll review why this needle. So again, now we're just going to want to recalibrate it up to that 2 so that we know we have 2 mLs, and if there's any excess, you could waste that into your medication waste container again. So before we move on, similar to all of our meds, we're going to want to make a medication label for this syringe before we carry on. So we're going to want to put the patient's name right at the top, the drug name, which is ampicillin, the dose 500 milligrams, the volume is 2 mLs. Diluent amount is going to be not applicable in this case, and you might be thinking, but we did dilute this. That's more referring to when you get into IVs and you're giving the medication diluted in something when you give it. This was to make the medication into a liquid, so it's a little bit different. We're going to write concentration per ml, because we know it's 250 milligrams per ml. That's what the information we got from our monograph. And we're going to put the date, time, and our signatures. So just like with the others, we can kind of carefully attach it to our syringe in a way that doesn't impede reading the markings, doesn't cover the markings. We'll just kind of put it on the cap, and we'll put it aside for now, and I'll just review why we selected that needle. So for IM injections, and now you can kind of put it all together. The muscle is the deepest tissue that we're going to go to for injections. So first we had our intradermal, which is the top layer, your dermis, then subcut is under that, and then intramuscular or muscle tissue is below that. So you can probably already imagine that we're going to want to go with a longer needle. So there are parameters. Different facilities vary just slightly on their parameters, but most are fairly similar. So depending on the muscle that you select or the muscle group that you select, you can do different lengths. Also depending on the size of the patient, how old they are, would dictate their size, but also maybe how much subcutaneous tissue they have between their skin and their muscles. So you have to go a little bit deeper on certain people. So there are lots of really helpful guides and charts out there for you to sort of plan that or understand. But generally speaking, about 5/8 or even 1 inch. For adults, about 1 inch to even up to 1.5 and 2 inches is your wiggle room to work within, depending on the site. And then 22 to 25 gauges are the most common gauges for intramuscular injections. So we chose, we say we have an average sized patient. We chose a 23 gauge 1 inch needle for that, so we'd want to make sure that we have the right needle. And then going deeper or further into selection of sites, how you choose which site is actually dictated typically by the type of medication and also by the amount that you end up drawing up, so the volume of the medication. So in this case, we calculated to get that 500 milligrams, we needed a volume of 2 mLs. So 2 mLs fits into pretty much every category of injection location. We could do that. Some facilities are okay with you doing up to 2 mLs in the deltoid. Some dictate that you should stay under 1 or stay up to 1, but just depends on the site's policy, so you'd want to check that. We'll perform, before we leave our med room, we'll perform our second check. So we've left the medication syringe out, we've left the vial that we took it from out. We'll prepare ourselves with a cotton ball and an alcohol swab. And we're going to review our MAR. So we have the right patient, Chris McPherson on our label. The drug name again is ampicillin, so ampicillin. And ampicillin is in fact where we took it from. The dose is 500 milligrams. So we have 500 milligrams. This had a total dose in here of 1,000 milligrams. So we could recheck this and review that we put in the 3.5 mLs of sterile water to get a 250 milligram per ml concentration. So we've confirmed our dose. The volume is 2 mLs per that calculation and recipe. So we want to make sure we have 2 mLs because 2 mLs is going to equal our 500 milligrams dose. And if it's 250 milligrams per ml, and the route is IM. So we have reviewed the chart for our facility, and we know that a 23 gauge 1-inch needle is appropriate for our patient in this setting. And then the correct time, it's every 6 hours, so you just want to make sure you're on one of those time frames and it hasn't already been given, and that it's within that 7 days that it was ordered for. So we've done our second check, and we can grab a pair of gloves and proceed to the bedside. We'll just go over first the different sites where you can do an IM injection on an adult, and the most common one for an infant, and landmarking. So, and you've probably, hopefully, had IM injections or vaccinations done in your deltoid. So that's one I think a lot of people know right away. So for landmarking at the deltoid muscle, you'll want to find the acromion process, and you can go ahead and try to feel that out on yourself too. It's sort of that bony prominence at the top of your shoulder point. Jake's isn't super obvious, but this is roughly where it would be, and you can kind of usually roll your finger over that. So you want to find that acromion process and then go about 3 to 4 finger widths down. Typically it's about 3, and then sometimes you're kind of told to line it up with the axilla too. So then you're kind of going to go right in that in-between spot where this is where the muscle will be. So this one's pretty straightforward, acromion process, about 3 fingers down, and then you're going to go right beneath those fingers within the line of the axilla. So you do see you have actually quite a bit of wiggle room in there, but pretty much directly there is where you'll want to go. Another popular site for an adult, or another site you can use on an adult, would be the vastus lateralis. So that would be along the person's leg, just lateral. So you can put a hand on the top of the knee, a hand on the base of the hip, and then it's that area, that middle third in between there that you can go with. So again, it's sort of a bigger area. So we could put a hand on the hip, hand on the knee, and we're going to go in this dense muscle area. So that's vastus lateralis on an adult. And then for a baby, vastus lateralis is the most common site for injection actually too. So obviously putting your hand width wouldn't really work. So you could just do like a 2-finger width marking, and then it's going to be that middle muscle section on a baby as well. So that's the most common site for an infant. And finally, the third site that we talk about and practice, and is actually the preferred site because it can hold the most amount of medication. It's the biggest, thickest muscle, and it's well developed in most people, is the ventrogluteal site. So this is sort of a model of a pelvis for demonstration. So I'm just show you the model, and we'll just tip them on their side. So just like with a patient, you would ask them to lay on one side, and then you'd want to remove their pants and underwear to get to the site. And we'll start by, for landmarking, you're going to use the palm of your hand, and you're going to place the palm of your hand right on top of their greater trochanter. And you can go ahead and feel this on yourself, or maybe a partner or someone, just to feel out that big hip bone. Even over pants, you can feel that stick out when someone lays on their side, kind of is that big ball socket joint. So on their greater trochanter, and you know you're going in the right direction if your thumb is towards the person's groin. So my thumb is going towards their groin. And then with your hand on the greater trochanter, you're going to use your middle finger to reach and touch and feel the top of the person's pelvis, which is anatomically their iliac spine. And then you're going to actually reach out with your middle finger towards their iliac crest. Some people with sort of larger hands can actually touch both their iliac spine and iliac crest at the same time. I can't, so I just typically reach that finger out towards it because your pelvis is sort of shaped in that way, so you just can reach out towards it. And then your site is actually going to be between those two fingers. And just to note, you wouldn't want to inject between your two fingers because you put yourself at high risk of being poked. So you'd want to landmark with your hand and then either maybe place the alcohol swab there so that you have that landmark noted, or maybe the person has a mole there, something that tells you I'm going basically just there, because you can go pretty much anywhere in this V. So we want to landmark it with something like an alcohol swab is common, and then you're actually going to remove your hand for the injection. You don't want to go between your fingers. So that's landmarking of the ventrogluteal site. Again, this is intimate, so it's maybe not used as often as it should be because of that, but this is a really good site for a lot of people because it's a well-developed large muscle again. So a good site to use. I'll just take this opportunity to show you on this model. Its buttocks is cut out, so it's got the adipose tissue here and the muscle here. This is actually the sciatic nerve, and this is showing you how close you can get to the sciatic nerve. We were somewhere up here, so we were actually quite far away, but there was sort of a traditional or old school of thought that a dorsogluteal site, which is in this area, was a good appropriate site. We don't do that anymore, so don't use the dorsogluteal site because you can see how close that does get to the sciatic nerve, so you increase the risk of complications with hitting that. Potentially can cause paralysis or lots of pain for your patient. So we just use the ventrogluteal, not dorsogluteal, and then that's just a visual representation of why. We've completed our checks. And now we're going to, and we've chosen a site, so ventrogluteal, and we reviewed landmarking of the ventrogluteal site. So for practice in the lab, we're going to do injections into these pads. So that's how I'm going to show the injection now. I would typically wear gloves for this, just so that for dexterity I won't in this video, but you can definitely wear gloves. Have our needle ready, and there's a practice called Z-tracking that you'll read about that's sometimes done with IM injections. And you want to, again, know your site specific policies and procedures if they do Z-track or if they don't. Some places choose not to. But basically, the theory behind Z-tracking is that you are displacing tissue. So usually using the ulnar aspect of your hand, this part of your hand, and displacing the tissue of the area you've landmarked already, and you're going to actually pull the tissue to the side. This skin pad doesn't move as easily as real skin, but you get that idea of you're kind of pulling the skin tight to one side. And the reason for that is you pull it tight and you do your injection with the skin pulled taut to one side. Do your injection, you instill or depress the plunger, and then you remove it, and then you let go of that displaced tissue. So if you can sort of imagine underneath, and there are some good diagrams in your text that show this, that displacement of tissue actually kind of seals in the medication so it stays within the muscle. So you'll find sometimes, especially say with the deltoid site, it's very hard to do that lateral pull for Z-tracking. So you can kind of work around that by pulling down on the tissue. So whichever way you're displacing it, you're sort of just pulling it tight. So if it works better, maybe someone has a bit of a smaller arm, you can pull down to do your Z-tracking, and then just hold it tight, do your injection, and let go only once the needle is out. So that's Z-tracking. And the other sort of difference with IMs and your other injections is that some places will want you to aspirate when you're giving an IM. And again, some places don't need you to aspirate when giving an IM. but some agencies do prefer you to aspirate. So the reason for aspiration is to determine if you get blood in the syringe, then that means that you've actually gone into a vein and not necessarily muscle tissue. So if when you aspirated you did see blood, you would want to start over again, because then you're not delivering it to the correct route. If we are doing this again in the ventrogluteal site and our agency dictates that they want us to Z-track and aspirate because we're not giving a vaccine, then we'll kind of show that so that you guys understand how to do that, and then you can adjust your practice accordingly per facility. So again, gloves if preferred. We're going to have clean hands doing this. We're going to clean our site with alcohol, have a cotton ball ready to go. And we're going to, once we've landmarked our site, we're going to clean it again in that circular motion. We're going to let that area dry, kind of do a big area there. About 5 centimeters out is good. We're going to let it dry. Just a quick note with aspiration, you probably noticed with subcutaneous injections, we don't aspirate. It doesn't, you're not required to aspirate at all. You shouldn't aspirate actually, because it can increase the damage to the tissue. And it's just a really low risk of hitting a blood vessel with subcut injections. So just kind of note that difference. We don't do that. We only do that with IM. So our alcohol is now dried. We're going to go over Z-tracking. So similar to the subcutaneous injections, it kind of helps to stabilize with that ulnar aspect of your hand. But because you're not grasping the tissue, you do actually have your non-dominant hand to use as well if you need. So I kind of like to pull the tissue aside. And with IMs, we're going to go at a 90-degree angle. So if you pull it aside and can actually obtain that 90-degree angle and stabilize that way, then that's great. But it's also, this is where, and it's hard to maybe see, but if I do the lateral pull or the pull down with my thumb and actually inject at my 90-degree angle like this, still stabilizing with that ulnar aspect, inject, and then I can stabilize here, aspirate if indicated, as we said, and no blood. So we're going to now slowly inject, maintaining that Z-track pull down here with my thumb. I'm not sure if you can see. And I would maintain my stabilization here as well. With my 2 fingers, I just don't want to block the view too much of the camera. But so we're going to instill, and you'll notice that I'm instilling rather slowly. Most of the literature does say actually to inject at 10 mLs or 1 ml per 10 seconds, sorry. And that to me seems like a really long time. It is a while, but basically the take home there is you want to inject slowly. You don't want to blast it in. That can be really painful, especially those larger volumes, that can be really painful. So maintaining that pull that we had, we're going to now remove the needle. And then you can let go of that tension on the skin. So we'll want to cover the person, we'll want to activate our safety, and discard that into the sharps. Again, we're not going to massage the site. We're just going to apply some gentle pressure there if it's bleeding. Maybe a Band-Aid is indicated. And we're just going to make sure the person is comfortable. And then we're going to document, sign our MAR, and discard and clean up our supplies.